This is the second lecture on the respiratory system. Gas exchange is going to follow the gas laws which apply in chemistry. The first gas law is Boyle's law. This states that the pressure equals 1 over volume, meaning the greater the volume of a given amount of air, the lower the pressure of that air. For example, if we have our volume a unit of 2, the pressure equals 1/2. If our volume is a unit of 4, the pressure goes down to 1/4. The air pressure at sea level on Earth is 760 millimeters of mercury. When we inhale, the pressure in our lungs decreases slightly to approximately 758 millimeters of mercury to pull the air in, and increases when we exhale to approximately 762 millimeters of mercury to push the air out. These numbers are approximate, and you will see some variation in the exact pressure with the different sources for the information. The key concept is that there is a decrease in pressure to pull the air in and an increase to push the air out. The second gas law is the law of partial pressures. This states that the total pressure of a gas is equal to the sum of each of its components. For our air, which is composed of about 78% nitrogen and 21% oxygen, the pressure of nitrogen at sea level is 597.4 millimeters of mercury. Oxygen is 158.8 millimeters of mercury. Water is 3.0 millimeters of mercury. Carbon dioxide 0.3 millimeters of mercury, and other gases total up to about 0.5 millimeters of mercury. All of these add up to 760 millimeters of mercury. If you increase the elevation to where the atmospheric pressure is half what it is at sea level, each of these components will be reduced by half as well, making the pressure of oxygen lower and breathing more difficult. This is an overview of the respiratory system produced by Wisconsin Online. So here we can see the air going in and out. When you breathe, what happens to the air that goes in before it comes back out again? The process is called respiration. The first step is ventilation, air in and out. External respiration is the process of gas exchange between the alveoli in the lungs and the blood. Some of the air you just inhaled from the atmosphere, which is in your alveoli, will now enter your bloodstream. The oxygen in the air that you just inhaled is more concentrated in your alveoli than it is in the blood vessels that come into the lungs. Because of this, oxygen will leave your alveoli and enter your bloodstream. There is a high level of carbon dioxide in your blood when the vessels enter the lungs, so carbon dioxide will leave the vessels and enter the alveoli. This carbon dioxide will leave your body when you exhale. What happens to the oxygen? The oxygen travels in your blood back to your heart where it is pumped out to a cell somewhere in your body. Oxygen is transported by the hemoglobin in your red blood cells, while carbon dioxide is primarily transported as bicarbonate ion. This process is known as gas transport. This process brings the oxygen from your lungs to the cells of your body and takes the carbon dioxide from the cells throughout your body and returns it to your lungs to be exhaled. After leaving your lungs, the oxygen diffuses from the hemoglobin in the red blood cells to the systemic tissue cells. The carbon dioxide that is generated by the cells diffuses into the bloodstream and is transported back to the lungs. Gas exchange occurs between the blood and systemic tissues is known as internal respiration. Respiration involves 4 steps. Step 1 is ventilation. Respiration, transportation, internal respiration. You will have access to this outside of this presentation so that you can complete this little quiz on your own. Blood flow is organized to carry oxygenated blood to the tissues and deoxygenated blood back to the lungs. Oxygen is very reactive and must be bound to hemoglobin to be transported in the body without causing damage. Diffusion will move the oxygen into the tissues to try to equalize the concentration on both sides of the respiratory membrane. Other factors help to increase the oxygen getting into the tissues. As carbon dioxide increases in concentration, this will take hemoglobin to release oxygen more readily. This occurs as metabolism takes place, since carbon dioxide is the waste product produced. As the pH decreases, oxygen will be released more readily. In muscles, when oxygen is inadequate, lactic acid is produced and lowers the pH. As long as temperature increases, oxygen will be released more readily, which also occurs along with more metabolism. Carbon monoxide is extremely dangerous because it will bind to hemoglobin 200 times more strongly than oxygen. This means it will essentially permanently bind to the hemoglobin, making it no longer available to carry oxygen until that red blood cell dies and it is replaced. With too great of carbon monoxide levels, a blood transfusion may be needed or the person will die. Carbon dioxide is normally produced from metabolism and is much less reactive in the body, allowing it to be transported in a variety of ways. It can also be transported on hemoglobin like oxygen. It can travel as dissolved carbon dioxide in the plasma until it reaches the lungs to be exhaled, and it can also travel bound to other amino acids in the blood or as the bicarbonate ion until it reaches the lungs. The control of our respiratory system occurs in the medulla oblongata and pons. The medullary rhythmicity area establishes our basic rhythm of breathing. We also have special inspiration and expiration areas in our brain. Ventilation is our process of breathing. Inspiration is the breath in or inhaling, and expiration is the breath out or exhaling. Different muscles are used at different points in our breathing. Our quiet respiration is what occurs when we are at rest. Forced expiration occurs when there is a greater need for air and we recruit additional muscles to bring in more air or force more air out. During quiet inspiration, the diaphragm muscle pulls down, the external intercostals contract. This pulls the floor of the chest cavity down and lifts the ribs up and out to increase the volume. During forced inspiration, the cavity is expanding even further using the SCM or sternocleidomastoid muscle, the scalene muscles, and the pectoralis minor muscles to lift the rib cage superior and anterior. Quiet expiration is a passive process where the elastic recoil of the muscles returns the thoracic cavity back to its resting position. In forced expiration, the internal intercostals pull the ribs down to decrease the volume of the rib cage. The internal and external abdominal obliques, the transverse and rectus abdominis, also contract to decrease the size of the abdominal cavity and displace the organs upward, pushing more air out of the lungs. This same displacement occurs during pregnancy as the growing fetus begins to displace organs upward, making breathing more challenging. This diagram shows the respiratory pressure cycle. As the size of the thoracic cavity increases, there is a drop in pressure to pull the air in or inspire. As the thoracic cavity decreases in size, it will increase the pressure and cause expiration to occur. You may notice some of these numbers differ here from what you may find in your text. That is not unusual to find slightly different numbers in different textbooks. The diaphragm pulls down to increase cavity size, pulling air in due to the vacuum. When the diaphragm goes back up, it will increase pressure, pushing air out. If the pleural cavity is not airtight, the air will pull into the space between the parietal and visceral pleura and not into the lungs. This will allow the lungs to collapse as air comes into the space around it and prevents ventilation. The spirogram provides a way of measuring different volumes of air in the lungs. A diagram of this can be seen on the following slide. The tidal volume is the volume of one breath of air during quiet respiration and is approximately 600 milliliters. The inspiratory reserve volume is the additional air that can be inhaled after a normal inspiration. The expiratory reserve volume is the additional volume of air that can be forced out after a normal quiet expiration. The residual volume is the volume of air left over after forcefully exhaling. Even after blowing out as much air as you can, there is still some space in the lungs that is filled with air that you are not able to get out. This slide here shows a spirogram with the relative volumes of air. The tidal volume is the small section in the middle. There is also a link that you can follow outside of this presentation that allows you to highlight these different areas in the spirogram. The inspiratory capacity is the inspiratory reserve volume plus the tidal volume. This is the maximum amount of air you can take in when starting from a finished quiet respiration. The functional residual capacity is the residual volume plus the expiratory reserve. This is the amount of air that sits untouched in the lungs while you are doing quiet respiration. The vital capacity is the amount of air that can be exhaled following a forced inhalation. This is the best you can do when you are blowing out birthday candles. The total lung capacity is the total volume the lungs can hold and is about 6 liters between the two lungs. We do have some voluntary control over our respiration with the cerebral cortex. We can choose to do voluntarily altering our breathing pattern to avoid inhaling water or certain gases. Our control is limited, and if we start to build up too much acid or carbon dioxide, our body will take that voluntary control away, we will faint, and normal breathing patterns will resume. This is measured using chemoreceptors in the medulla oblongata that measure and respond to carbon dioxide levels in your cerebral spinal fluid. The limbic system can influence the respiratory rate and will increase respiration with anticipation and anxiety. The mechanoreceptors respond to exercise and activity by triggering an increase in respiration, as well as the temperature increasing respiration. Different types of pain will have different effects on respiration. Visceral pain or organ pain will decrease the respiratory rate, while prolonged or somatic musculoskeletal pain will increase the respiratory rate. Sudden or severe pain will lead to brief apnea or temporarily holding your breath. This can be useful to determine if someone is in pain who is not able to communicate. This can include infants, elderly, or even maybe your pets. With airway irritation, we can temporarily build pressure to cough or sneeze. There is an inflation reflex in our lungs when we take a deep breath and stretch the receptor in it that will inhibit inflammation. This is the reason behind breathing deep to try and decrease and manage pain.